Hi, everyone. Welcome to the show. Welcome to My Baby Experts. We are so excited to have you here tonight. And I'm going to just check my screen here to make sure that we are broadcasting, but I can see the button. So, there we are. Hello, everyone. Welcome. Wonderful Wednesday night. And I'm so happy to be back with all of you. And we have some new people, a lot of new people joining us. And boy, do we have a show for you tonight. I am so excited to be able to bring you this very, very important topic, and even more so, so excited to bring you our very special guest. But for a moment, I know that we have a lot of new people jumping in. Many of you have been with me for many, many years, and some of you are new. So I just want to take a moment to introduce myself. My name is Shari Criso, and I am a registered nurse, a certified nurse midwife, an international board certified lactation consultant, and of course the host of the My Baby Expert show, which this is actually our episode 111, which I happen to think that is a very, very lucky number. It's also my birthday, 111. So I take that as a really good sign that we're going to have an amazing show tonight. I was happy to see that. Everyone's jumping into the stream right now, and I'm really happy to see all of you here. Let's give it a minute and let everybody jump in before I get a chance to introduce my special guest and the topic for tonight. So they're all saying, hi everyone, I see you guys. Okay, so tonight we have an amazing guest and topic, and the topic is tongue and lip ties, which I know all of you have been asking about, posting questions, lots of misinformation, misunderstanding, just a lot of confusion and questions. And so I, made sure that we got the very best person to join us tonight to answer all of our questions, to have a really great conversation about everything that we need to know as parents and also as practitioners. And what I loved seeing from all your RSVPs, and we had a lot of people saying they were going to join tonight. We had a lot of nurses and doulas and midwives and lactation consultants joining us as well, which just made my heart so happy to see everybody jumping in and learning, with all learning together. So without further ado, I want to introduce my special guest who's sitting right next to me here virtually, and this is Dr. Scott Siegel, and he is an amazing oral and maxillofacial surgeon, and he's the pioneer of lip and tongue tie surgery, located here in New York City as an office, and also in Long Island. And so I'm just excited that I am close enough to him where I can refer my patients to him and to have him here to talk all over the country and the world, because we do have people from all over the world right now logging in. So it's super exciting. Welcome to the show, Scott, Dr. Scott.
Oh, thank you, Shari. It's very exciting. I'm very pleased and happy to be here. This is my first Facebook Live presentation, so bear with me, but it's super exciting.
Yeah, well, we're so happy you're here. And I know a lot of even your patients have been writing to me saying, we love Dr. Scott. So they've all gone to you got a lot of support in the audience. Let's all say hi to Dr. Scott. It's his first time here on Facebook Live. And yes, they're all on there saying, thank you, Dr. Siegel. Yeah, this is such a great medium here for us, a great show. We have an amazing community of really interested moms and dads who just want to do the very best thing for their children and get the right information. And the idea for this show has always been, when people ask me, why is it called My Baby Experts? You're an expert. Why is it plural? And the answer is nights like this. It is always about bringing on the very best out there in the areas that I'm not the expert in, to bring the information, the right information to parents everywhere so they can make the best choices for themselves and for their children. So I really appreciate you being here with us, and I know everybody else out there does too. So
thank you. Thank you.
Thank you. Thank you. So let's first of all, let's ask everybody where they're from, because I love to get a little bit of a sense of where everybody's from in the country, and also you'll be surprised in the world too. So everybody go ahead and post right there. Where are you all from? Where is everybody from? And go ahead and post it there. And the other thing I want to see is a hashtag 111, because it's a celebratory night for this episode. So hashtag 111 and tell me where you're from. Awesome. There we go. Okay. Cleveland, Michigan, Washington, Oklahoma. We are everywhere. Everywhere. Pittsburgh. Fantastic. Yay. Here they come. And there's a little bit of a delay, so I'll ask the question and everybody will start to answer. Okay. Awesome. Yay. Okay. So what we're going to do, I want to give Dr. Scott an opportunity to really tell us about yourself. Tell us how long you've been doing this, how you got started, and your background, because it's just so extensive and so fascinating. I want everybody to know who they're listening to tonight.
Right. Yeah, there's most of you that probably don't know my background. It's kind of an interesting background. I hold both a dental degree and a medical degree. So I went to dental school and I went to medical school. And I've been really focusing on tongue ties and lip ties and what we kind of term tethered oral tissues now, really for the past 17 years that I've been in private practice. And I essentially was turned on to this subject when I was in medical school. I happened to be, when I was doing my surgical rotations, one of my mentors or advisors was a pediatric surgeon whose name was Elizabeth Grillos, who Betty, as we affectionately call her, or Grandma Betty. And she was a tongue tie pioneer. She actually has a classification system named after her. And it was in medical school where I started to kind of learn a little bit about it. And when I went into my general surgery residency, and she was one of my mentors, and we would do, I always joke around, we would do tongue ties and circumcisions in the operating room together. And when I went into private practice in the year 2000, it turned out that her private office was across the street from me. And it was at that time when we were starting to get involved with ultrasound studies and breastfeeding infants before and after frenotomy, looking at the differences. And she was a scissor surgeon, and I had used laser in oral surgery. Right. And essentially, 17 years ago, she started asking me to do laser work on her babies, especially dealing with these quote-unquote posterior tongue ties, which I really had no idea what that meant at the time, but we will talk about that later. Right. But that really kind of, was the impetus for my jump starting of this career, and I really have made it my lifelong passion in treating not only babies, but all different ages of children with tongue ties and lip ties. And as you know, we see all the time, it's an often either undiagnosed, misdiagnosed, or some other sort of excuse given for these issues. But that's kind of in a nutshell, that's my history. As far as, I belong to many organizations that deal with breastfeeding. I'm an active member in the Academy of Breastfeeding Medicine. I'm a fellow of the American Academy of Pediatrics, the American College of Surgeons. And one of the focuses is bringing this to the forefront of general medical education. Trying to get the medical community and the dental community to understand really what we're dealing with.
Yeah.
Pretty much
It's so needed, and you're doing such amazing work, and we know, as myself as a nurse midwife, as an IBCLC, I know how much this is really not understood very well by physicians and practitioners and parents. And so I think what you're doing is amazing. I recently had the pleasure of attending Dr. Scott's symposium in New York City 2 weeks ago with a whole panel of amazing experts in this field of just holistic care, of being able to use different modalities to support which we'll talk about in a little while, and be there with all the other practitioners. And it was really an amazing experience. So I was glad to be there with you. And I thought, wow, the whole time I was sitting there, I was like, thank God we're doing this live stream, because there was so much that I learned, just sitting there listening, that I didn't know. And so to be able to bring this now to everyone out there, and anyone who couldn't make it, or, parents who need to hear the information, is really important. So I really honor you for your commitment and your mission. And I know how committed you are to your patients, and they all love you. That's why. So, and you've helped a lot. You've helped a lot of people from what I've seen. You've helped a lot of people, including some of my patients. So let's get right into it, because we do have a lot of things to discuss, lot of different things to go over, and also a lot of questions that came in, and I want to be able to answer some of their questions. So let's start with, we have people who joined us tonight who said, I have no idea what you're talking about, but it sounds interesting. So let's start with what is, and when you're in this field, you kind of assume people know what you're referring to, and many don't. So let's start from the beginning of just what is tongue tie, lip tie, and as you referred to it as tethered oral tissues, like what are we discussing here?
Well, basically, we're discussing, if you look inside your mouth or anybody other's mouth, we're talking about those little attachments. So the attachment of the lip, if I lift up my lip, you'll see a little attachment going from my lip to my gum.
Yeah.
If you look underneath the tongue, there's usually some sort of attachment from the tongue down to the floor of the mouth. We'll show some pictures.
I think I have an actual picture right here. Let me pull that up just to start off with, so everybody understands what it is that we are describing here. Hold on one second. Okay, there we go. Can you see that?
So, basically what we're looking at, these little attachments, if I can, point out with the arrow, which we call a frenulum, which is, the definition is some sort of attachment that attaches a movable object to a more fixed location. And they do have a function. The issue is as humans are evolving, and we're not really sure, the exact cause, but we're tending to see that many of these attachments are either too tight, too short, they're restrictive, and they cause problems. And the problems we'll be discussing tonight range, from infancy up through adulthood. But in most cases, they start to cause feeding problems. They cause problems with digestion. They cause problems, with breathing, with growth and development of the jaw bones, and a whole host of other things that we will discuss. But the simple definition is basically it's this attachment that there's in the first trimester of fetal development. There's basically an incomplete dissolving of this attachment. And oftentimes the children or infants are left with this, if you want to say, incomplete or overgrowth of the attachment, and it causes issues with function and growth and development. So that's kind of in simple terms, what we're dealing with here.
Right. Yeah, so those were images of the tongue tie, and then we also are talking about lip ties, tongue ties, and also buccal ties, which would be within the cheek.
Correct. Yeah.
It's sort of like it can be in multiple places.
Yeah, you can have multiple places. There's been defined as essentially 7 spots or so that people can have these restricted frenulums. Although everybody's anatomy is a little bit different, so some can have many. I've had some people that have these webs, as we call them, all over the place.
Wow.
How they impact.
So, we're hearing about it a lot more now, but what is the history of this? I mean, is this something new? Is it like, and I've had people say, oh, this is a new thing, it's a fad,
Right.
Never had this years ago, and I've never heard of it before. And what is the story with, the history of this, and where we've come to?
Yeah, it's very interesting when you really look into the historical aspect of this, and there's people looking at that, and if you look back in even ancient Egyptian hieroglyphics, they talk about tongue ties and tongue tie releases in and that was there's a doctor in Israel who looked at that and found that throughout history, this is not a new phenomenon. It's not a fad. This is something that's always been there. We're not sure. Maybe there is an increase in prevalence or incidence. We're looking into that, or is it just the awareness, or is there some sort of issue with human evolution that is causing these issues as well? But when you look, even in the recent history, the recent past, pre-formula literature, this is a very commonly performed procedure. It was commonly screened for in hospitals and nurseries. Midwives used to, and you look in the literature, and anecdotally, they would grow their fingernails long and swipe under the tongues and release these babies upon birth. Even many old-time pediatricians that I deal with their own families come and say, "What's the big deal? We used to do this all the time in the nursery." And then formula came into the show, and this kind of went to the wayside as far as medical education is concerned. And I think there's like a whole generation of people that really have undiagnosed or misdiagnosed issues. And we are just now starting to see some of the effects of that and understanding the effects, with sleep apnea, airway growth and development, and some other issues.
Right.
But, there's been a resurgence in the past 10, 15 years of looking at this. So there's a lot of naysayers who say it's a fad or whatnot, but when you really do the legwork in the literature searches, it's always been there.
And I would assume that that's probably the case for much of the medical training that the pediatricians receive, and maybe part of, and we're going to get into that a little bit later, of just, why it's not accepted or what the controversy is over this. But I would assume that because it was kind of a lost art, like you said, once formula came into the picture, it was sort of the solution was to just maybe a bottle, which that doesn't really, it affects bottle fed babies too. So it really isn't a solution.
Correct. Absolutely.
Yeah.
It's very frustrating. And we're starting to see some changes. It's slow, and it's whenever you deal with anything in medicine, it's a slow turnover. But, I think we're getting there. One doctor at a time, one school at a time, trying to educate. So it's a process.
Yeah. Absolutely. Absolutely. And I think, not only educating the doctors, but educating the parents, which now with social media and Facebook and these kind of live streams, we can go direct to the source of the people who really need to know, which are the parents and the moms, the breastfeeding moms, the babies, the advocates of those babies that are going to say, hey, we know this exists. We know there's an issue, and they're going to demand that kind of care. And that's what I'm kind of hoping that will happen from just getting this education tonight. Will be the beginning of that.
Absolutely.
So is it a hereditary thing? I mean,
there are definite, genetic tongue ties. They seem to be multifactorial. So you will see some that do run in families. Many times you'll see there's been genes that are isolated for these issues, tongue ties. And there's also other things that we're looking at as far as environmental influences, including, genetic issues with the MTHFR genes, folate, folic acid, increasing that in the prenatal vitamins. There may be some sort of correlation with that and the increase in tongue ties. There's people actually looking at diet, basically human diets that have changed in the industrial age, which if they're looking and evaluating actually skulls from Neanderthal times when there was more of an agrarian diet or vegetable diet sort of thing, or paleo diet, if you want to call it that. And there seem to be differences in skull shape, or palate shape, which they're theorizing may have, been related to tongue position.
Yeah.
So there's a lot of different factors, but genetics does play a big role in it.
Yeah. And so this occurs while the baby is in the womb as a fetus. There's a certain point of development where this will take place.
Right.
So you've got the genetics, and then you've got also the environmental impact possibly during the pregnancy or exposures or anything like that.
Right. And that's one of the things I always say is, these babies, they develop it in the first trimester. And then for 2 trimesters, they're actually starting to deal with sucking habits and swallowing habits in utero. So when they come out, they're already kind of preconditioned to maybe not having an organized suck and swallow, and it's always, something that just pops up right out from at birth.
Right. Absolutely. Yeah. So as let's talk about that for a moment. Let's move on to, the impact on breastfeeding and infancy. This is the first sign we're going to see of these tethered oral ties, and that impact. The first impact is typically going to be on their breastfeeding experience.
Right. And that's, from our standpoint, in a perfect world, you'd want to be screening all of these babies as soon as they're born. Just like they're doing their APGAR tests and scores, let's look. And there are actually, Brazil, interestingly enough, is doing that at this point as a national law. But, as soon as they're latching, you should have an educated lactation consultant there, bedside or wherever is the most conducive place to do that, to assess.
So you're saying in Brazil, they're actually looking at all babies now in the hospital?
Yeah, they've made it a national law that the babies need to be screened before they leave the hospital, and at least hopefully screened and treated, because they've really realized, especially as they've been tracking older kids with myofunctional disorders, airway disorders, and sleep apnea, they were tracking that back to the underlying cause, which we'll talk about a little later, but tongue ties.
Yeah.
So
I want to pull up a screen here, and it's something that, I always like to go over facts and myths, and I thought this was a good one to go over some of the myths when it comes to tongue ties and lip ties, because these are the ones we'll hear a lot. So I'm going to pull that up for a minute and we'll go through them. I think that, hold on. Okay, hold on a second. Let me get there we go. Okay, so these are some of the myths that exist when it comes to ties, right?
Yeah, so each of these, basically these are kind of very common things that maybe you'll hear from a pediatrician or some other, and I do not, I'm not poo-pooing or downplaying any of other health specialists, but these are things that we hear all the time coming from, doctors' offices. And each of these things is really kind of being disproven with research. The experience has been out there, and we talk about experience, but pediatricians and other doctors and other healthcare providers want evidence, and they want evidence-based medicine. Mm-hmm. So, we go down these lists and they say tongue ties don't exist or it's a fad or whatnot, but, the literature's out there, the experience is out there, the number of patients that we see on a daily basis that, have immediate changes after treatment is there. The fact that they do not affect breastfeeding, a lot of these speak for themselves. The interesting things, a lot of us did think that, maybe they'll stretch over time or they can correct themselves. What we have been finding is that kids learn to live with them. They compensate, they grow with them, but they don't really stretch. They don't correct themselves. There's a nice study out of Brazil, actually, that looked at the collagen types of these frenulums, and it's essentially kind of similar to like a tendon or a ligament. They'll stretch to about 3%, and then that's it. They get so tight and taut, the only way to get past that is either tear it or cut it surgically. Yeah. And, some doctors will say they don't really cause maternal discomfort. Tell that to a mom, who has a baby chomping on them and their nipple and ripping it apart. Yeah. More recently, there's been, the push looking at how they affect speech, growth and development of the airway, the jaws, the teeth, and breathing. And there's a lot of research looking at that right now. Some really good studies showing the correlations.
Yeah.
So you go down that checklist and you can kind of, discredit each one of those.
Absolutely. I wanted to pull that up because these are the common things that people will hear in relation to so many different aspects. And as you could see from that list, it wasn't just about painful latch. It was so much more. And so I thought that was important to, at least for everyone to see. And so that when they hear these things, they could say, wow, that, we know that's not true. That's just not true. So when a baby is, after the baby's born, how early can it be identified? Right there in the hospital, right?
Immediately upon birth, and it can be treated immediately as well. The issue with a lot of what happens in the hospital, you really want to make sure that you have a qualified provider who knows what they're doing, and really, some people kind of oversimplify it and say, oh, we'll do a little snip and they're fine. But we've been finding that a lot of times they're incompletely done. They do a little snip, they tell the parents everything's fine, and then moms or the family still go home and struggle. So we're still very early on in trying to, get protocols down.
What are some of the symptoms so say that doesn't get identified in the hospital, that there's nobody there qualified to identify it, no one's routinely screening it, which is probably the majority of the hospitals right now are not routinely screening for this, or even, and we've heard even from lactation consultants who say, I try to talk about it, and then I'm told, do not do that, which was really upsetting to hear. And we know that, and lactation consultants are like the best people right on the front line who keep identifying it, but not everyone's listening. Right. So, what is a mom? What are some of the symptoms that moms could start to look for once they're home, they're breastfeeding, and
yeah, I'd say the most common symptoms that you'll hear across the board is when a mom goes home. Sometimes they'll latch okay in the hospital, or somebody says, oh, they look good from the outside. Now, what's going on a lot of times, the babies will have a shallow latch. They'll keep popping off the nipple. Many times they won't be able to get a deep enough latch, so they start chomping. When their tongue is tied, they don't really get this nice wave-like motion of the tongue going on. Yeah. So what happens is the nipple stays at the front of the mouth of the baby, and they start chomping on it. A lot of times, I'll make the faces where they're chomping, doing all these crazy movements, and they're really trying to get a deeper latch. And whenever I do that movement, the mom's like, that's exactly what's happening. And the fathers can see that too, and they can identify with that. Yep. A lot of times we'll have fathers who really don't believe that this is going on, and they'll say, oh, not my baby, there's nothing wrong with my baby, but the mother is really going through a agony. There's painful latching, there's biting, chomping, maybe the baby's getting exhausted, they're tiring out, they're cluster feeding. There's a whole host of things that you could tell me more than I can tell you about.
Yeah, absolutely. No, I mean, what you'll see is that babies that are just struggling to eat, they're nursing all the time. They're not able to transfer milk. The baby needs to suck a certain way for them to be able to actually get the milk to transfer. If the tongue is not moving, and the tongue is such an important organ in being able to suck and express the milk, if it's not working well, you're not going to get that milk to come out. And on top of that, because of supply and demand, if the milk is not expressing and the baby's not able to drain the breast, over time, what you can see and will see is a decrease in milk supply, and then all of a sudden the mom just is told you're just not making enough, and start supplementing, and these are all not issues that is inherently there for mom, but has been caused by an undiagnosed tie that could have easily been corrected and resolved the issue. Or the two most common issues that I see, and probably most lactation consultants see, for early weaning or discontinuing breastfeeding, is that they either didn't make enough or that it hurt too much. Those are the two things that I see. And both of those things not that all of them link back to this, because sometimes it's an improper latch, or sometimes it could be, other issues with milk supply problems, hormonal issues, things like that. But it's interesting to see that both of these things can be related back to tongue and lip ties, and they are the two most common reasons that moms give up on breastfeeding earlier than they want to.
Right.
Mm-hmm. The other things that moms can see, and you brought up the clicking sounds.
Right. Using the latch. Noisy feeding, clicking noises, and just usually a lot of times you'll see they'll go for a feed, maybe an extended feed, 45 minutes. You'll hear an hour, maybe on each breast sometimes, and at the end they're still starving, or they'll exhaust themselves and then they're ready to feed again. These feed episodes, and the babies some of them will compensate well and gain weight. Many do not, but many do. And that's one of the things that, one of the issues we have when you go to many pediatricians who do not understand what we call feeding efficiency is they'll look at a baby at, point A and then point B, say, oh, they're gaining weight. And that's one parameter they look at, but they don't look at what's going on throughout the day of how that baby is gaining weight and what's going on to get that baby to gain weight. So, the whole family is basically struggling here.
And that can especially happen when a mom has what we call an oversupply. So especially right in the and for most moms in the beginning, you do have an oversupply where, you do have more milk, you're engorged, there's more in the beginning, and then that starts to weight off a little bit as time goes on. But, in those early days, milk can just be ejecting out and the baby's swallowing milk, but milk and getting enough milk, but that doesn't mean that the baby's efficiently sucking at the breast. And what you will see is that over time, that will start to decrease more and more and more. So I'm sure you see that. That's what I see too.
On average, usually around 3 months, 5 months, when they start going through growth spurts and, feeding on demand is there and the supply starts to go down, their needs go up, and then they hit this, wall, essentially, as we call it. I had 2 babies today like that, where it was undiagnosed, and all of a sudden the babies hit a wall, mom's supply dried up, started to having to pump and supplement, and it's a daily occurrence that we see.
I always say to moms, if you have a lot of milk in the beginning and you're breastfeeding on demand and frequently, I don't really know too many reasons why your milk would just dry up for no reason. That just doesn't really happen in the absence of something that's causing it. Mom's milk should not just dry up if you're feeding frequently and around the clock. And so you hear this all the time where moms say, I was doing fine and then my milk just dried up. Right. And so I had to switch to formula because my milk, and moms are always so, as mothers, we tend to blame ourselves that there's something wrong with us.
Right.
And that's why it's important to understand that there are other causes. I know that there was a question that came in. Let's answer a couple questions because there's one that came in from Lauren. And she said, is it possible for there to be a lip and tongue tie and there not be any feeding issues? My son is 6 weeks old, has a mild tongue and lip tie, but he's a breastfeeding champ. The only thing he seems to have an issue with is gassiness and needs to be burped a lot and he spits up. Any thoughts about that?
Well, yeah, again, that could be a symptom of tongue tie. So, or lip tie. And it's basically, it's a couple of things that tends to happen with that. One is that if they do have a lip tie, many times they don't form a good flange or seal, sticking that fish lip. And then tucked in, many times they'll suck the air in. If they have a disorganized swallowing with the tongue, many times they'll gulp and swallow air. We call it aerophagia. These studies that I do, my research happens to deal with digestive issues, reflux associated with this, and call it aerophagia induced reflux, or AIR. One of the other theories is that, when they're disorganized, sucking and swallowing, their sympathetic nervous system is elevated. They get more gassy, more irritable. They get labeled as colic. So those are actual symptoms of tongue tie. So I wouldn't say it's asymptomatic sort of thing. So,
right. So when she's describing, this is such a perfect example.
Those are red flags for us who sit there and like, that's a functional issue right there. Right. So that's not normal.
Right.
So
I just posted today on my Facebook wall. When I was in Austin a couple weeks ago, I had a couple that raised their hand in a Q&A. Asking about, they have twins, and the boy baby, she raised her hands over fussy gassiness issues, and it was like, after asking questions, I was able to say, you need to get the baby evaluated for tongue or lip tie, and I just got a message back from her today saying they went. It was absolutely there. They had a revision. The baby is doing so much better. All the fussiness, all the gassiness went away, and the baby's starting to gain weight properly. And now they even suspected in the baby girl as well. So sometimes someone may present with the, my baby's a breastfeeding champ, everything's fine, we have no breastfeeding issues, but this actually is an issue. And all that swallowing, especially when you've got all these babies diagnosed with reflux, and now they're on all these medications for reflux that are not really working, or they may be working and they're doing a little bit better, but at what cost? And are we really identifying and correcting the actual cause?
Right, and that's really kind of the impetus of my research looking at that. Was we found that so many babies were coming in, and you hear the horror stories actually of babies that are undiagnosed or misdiagnosed, and they wind up with these feeding issues and being put on major medications or going through invasive testing like scoping, and they're bypassing the mouth where it all starts, and they're going down below, trying to look for other causes, but they're missing the cause, and they're treating symptoms, and that comes at a cost. So we really try to reevaluate how we evaluate these babies that way.
Yeah, absolutely. And it's great for parents to have that in the back of their mind too. The baby's fussy. Sometimes they need to be burped a little more. That could be the reason. Sometimes it could be just an immature digestive system. Babies can have some reflux. And sometimes it could be something completely different, as was the case.
Something to add to that list that should be on there for them to.
What we're not saying is that every baby with any kind of spitting up or reflux has tongue tie, and not every baby with a tongue tie has spitting up or reflux.
It's just something that should be on what we call the differential. So when you're looking at a baby that has those issues, they should be screened for lip tie and tongue tie.
Awesome. One other thing that I read, and I want to talk a little bit more about when it comes to this as well, is the idea of and the correlation to possibly SIDS and some of the research that's being done with that, because I don't think a lot of people understand that they're finding some links.
Right. So interestingly, we look. I guess we're backtracking a little bit because we have found, and there's some big studies looking at correlations or links to tongue ties and sleep apnea in children and adults. So taking that backwards, is there a relationship to other sort of, breathing disorders or apneas in infants? Mm-hmm. And there was a study done down in Florida by Dr. Haller, who's a dentist, but she's a forensic dentist and had access to, the medical examiner's office. And we're able to look at babies that had died from SIDS. And one of the things, interestingly, that they found was that there was a higher incidence of lip ties in these babies. Yeah. Now, they looked at lips because I think that's one of the things they were allowed to look at. I don't think they were allowed to actually look at tongues. But genetically speaking, when we see a lip tie, almost 100% of the times, maybe it's 95% of the times, you'll see a tongue tie as well. And so that needs to be investigated further. It's not saying there's a direct link, but I think, we could be onto something there. And it just, like with all of these things right now, we're in its infancy and looking, pardon the pun, but looking at these issues and how they impact. So, there's a lot of people looking at this.
It's really good, because it's one of those things where, people relate this. I think when they start to think about it, they're only thinking about feeding issues. And if you just go to a bottle, then you've solved everything else, when now we're seeing that it's not about that.
That's a common question I have. The families will come in and say, well, if it's just about breastfeeding, I'll pump, I'll do bottle or whatnot. And then they say, if it can impact other things, and then we'll go down the list, that we talked about before. And we look at risks and benefits. And if you look at the risk of doing a procedure like this, that is really a minimal risk. And many of us who do these procedures will compare it to another commonly done procedure, maybe in boys, like a circumcision, that really has not shown any medical benefit, but, there's certainly cultural and religious, issues with it. But medically speaking, it really does not have a medical benefit, but it has a fairly high complication rate. Yeah. When you look at sternotomy or frenectomy in an infant, the risks of that are minuscule. So
such a good example, because it's one of those things that are done so routinely, and yet there's
it's like is your son circumcised? If it's a girl, that's not another story, but we'll see that and say, yes, well, this is much less than, of a procedure than that, and it has way more medical benefits, not only now for the feeding, but for the future. So that's one of the things we'll lay out there for families.
Absolutely. Absolutely. So let's talk a little bit about how it's diagnosed. So once you you maybe mom's suspecting it, or it may be just during a routine visit with a knowledgeable practitioner, whether it's a lactation consultant or someone's identifying it. How is it being identified?
Well, if just say at home, a mom or dad wants to really look at their baby to see if they do have something going on. I don't know if we have the pictures of, but there's.
I have, let's see. Let's see what we have.
I don't know if we have that, but just even lifting the lip up. If you want to come behind your baby, lift the lip up, you'll often see that little, piece of skin. And if it's detached low on the gums, and when you lift the lip up towards the nose, many times you'll see that the gum starts to turn white. When that gum starts to turn white, it's called blanching. It means that there's too much tension being put on the gums. Oftentimes you'll see, and just another simple way to look for, lip ties, if the baby's on the breast or on the bottle, the lip just stays tucked in all the time. And mom will say they keep trying to flick it out to flange it. They'll get it out and it'll tuck right back in.
Yep.
That doesn't mean it's an absolute lip tie, but it's more likely that that baby has
right. They're having a harder time keeping their lip flanged because something's holding it back.
Correct. It's just like a rubber band, just keeps pulling it back in, and that's why we kind of call it a tether. It just keeps pulling it in.
Yeah.
And the same sort of thing with the tongue. Now, tongue ties can be a little bit tricky, and they're sometimes even tough for professionals like myself who deal with it all the time to diagnose, because there are different types.
Yep.
Many times there's a fallacy that you'll go to some sort of healthcare provider and they'll look at the child and say, oh, they can stick their tongue out, they don't have a tongue tie. And reason they're really looking at for what we call an anterior tongue tie, which is usually that little web that most of us think about.
I do have a picture of that. Let me pull that up while you're talking, because this is, I think, confusing for people. So what's the difference between that anterior tongue tie and the posterior tongue tie? Let me pull that up while we're talking here.
And I think that's an important thing to really kind of, think about, because even from when I first started, going on 20 years ago, I really was so confused for a long time about what that meant. Doctors, when you think of posterior tongue tie, thinking of something way back, almost in the throat. But it's a very, when we talk about anterior tongue tie, there's maybe just a little thin membrane, a thin little web, if you want to call it that, at maybe from the tip of the tongue or right behind the tip of the tongue down to the floor of the mouth. Now, a posterior tongue tie is when really kind of you're missing that little web part, and then you have more of a thick part. I don't know if we have the clinical photos of that, but
I do. Let me see here.
And this schematic kind of, if you want to talk more in schematics here, when you look.
Here we go.
So this is an anterior tongue tie, right in between the Q-tips, this little thin membrane. Now, interestingly enough, if you go back here, kind of where this second Q-tip is touching, it gets a little thicker. That's really called the posterior component. So if this thin membrane was missing, you'd still have the tie here. There's still restriction. So we find when people snip this with a scissor, a lot of times they'll snip back to here, but they don't go further back or far enough back. And that's what that schematic with the sailboat was kind of meant to describe, which I can go back to in a little bit.
There's the sailboat right there.
So when you look at the sail part here, that's really kind of that membrane, or the anterior tie, or the anterior component. And the mast is what we call the posterior component. It's basically a band or thicker band of tissues. So it gets a little confusing for many people, saying, well, if there's, so this is talking about the posterior tie here. So you don't see that thin little membrane, but as we come further back and start to lift the tongue up, you'll see a thicker band kind of pop out. And, so this sometimes if we have parents at home trying to figure out what they're dealing with, which is not an easy thing to do, we usually recommend just bringing them into a trained, you know, professional, or many states have what you call preferred providers. Some of them are listed on social media websites. And that's basically just based on, I think it's more, parental and family experience. But they can be very tricky to look at and diagnose.
Yeah. So who would a parent actually go to have this diagnosed? Because
Well,
we've heard, you hear pediatricians, ENTs, lactation consultant, like
right.
it's everyone.
Very confusing. I live in New York, and you would think it's one of the cutting edge places to be, for medical care, and I find it to be one of the worst in my experiences, that these things fly under the radar on a daily basis. I don't have great advice for that. I find that the lactation consultants are really the best to be screening for this.
Yeah.
And IBCLC is really, the gold standard. Unfortunately, for whatever reasons, you're not allowed to quote unquote diagnose, but I depend on your diagnosis, for treatment of these babies. So I really think the IBCLC is really the gold standard here, and usually the team leader for us.
Yeah. Yeah. And probably the person or the practitioner that's actually supporting the mom to get all the different care that she's going to need, because we're going to see most of these issues start when they're trying to breastfeed.
Right. And you guys spend the most time with the families, with the mom, and figuring out exactly, the maternal factors that are going on, the baby factors that are going on, and really kind of help.
Right. How many pediatricians' offices, I don't know, anybody in the audience here, you'll go in, are your pediatricians really sitting there watching you breastfeed, spending some time with you to watch how the latch is, to make sure that, is everything okay? And then from there, being able to identify that there's nothing really wrong. It's not the latch issue. It has to do with the structures of the mouth that are causing it. So, yeah, they usually don't have the time or even the knowledge to do it.
Yeah, I think it's more just the knowledge, and it's not their fault. It's just,
they're not trained. They're not trained in pediatricians are not breastfeeding experts for the most part. I know a few that are actually IBCLCs.
Yes,
Very few. And those are the ones that you would want to work with and trust. But when it comes to your breastfeeding issues, and I say this all the time, they're just not the experts. They're not the specialists in breastfeeding. And if you're really needing support, you really need to be seeing an IBCLC for that. Yeah. So question is, let's ask a question here. It was, let's see. I think you just answered that. This was about if the baby has a lip tie, they almost always have a tongue tie as well. And you said about 99% of them as well have the tongue tie. And the posterior ties are often missed. Is this true? We have a definite lip tie, but I don't see a tongue tie, and the pediatric dentists locally are all unfamiliar with ties. What does somebody do if they, everyone they're going to see is, do they need to travel? Who would be an alternative for them?
Yeah, it's very tough. I mean, a lot of times we do wind up, seeing families that travel to get the expertise. That's really kind of the bottom line.
Yeah.
So.
I know people who have traveled hours to go to someone who knows knowledgeable.
Yeah, absolutely. You get families that fly in from other countries to do it. Even though it's relatively a simple procedure, you still want to make sure that it's being done by somebody who does a lot of them, has the knowledge.
And I know there is a directory of practitioners, and maybe someone in the chat room who knows that link right now, because I didn't give it to Joe. Joe's my husband. He's in the other room posting as me. So if you see me posting there, I'm not that good. It's actually him posting. But if somebody has a link to that directory, that would be great to go ahead and post that up, or we can provide it later. But just to have a listing for moms out there all over the country of who they can start to look for. Do they always need to be treated, Dr. Scott? So this idea that, okay, it's a small tie, it's a little tie. Do they always need to be treated?
No, and that's an interesting thing. I have, many patients that we follow, and a lot of times, most of us who deal with these things, we're really kind of focused on the function.
Uh-huh.
And if you have a baby that maybe looks somewhat like it might have a restriction or a tie, they're functioning great, they're, seemingly growing okay and meeting their milestones, yeah, we'll give the options. Some parents will want to do things just for prevention. So, they'll take that approach. But
Right,
you certainly wouldn't push anything on a family like that. And we
right.
do have plenty that we do observe. And we find some that do beautifully and they're growing without a problem. So it's not, just because it's there, you have to cut it.
Yeah. So speaking of cutting it and doing it, let's
Right.
talk a little bit about the revision process itself. Like what exactly do you do? I know you do laser revision. What is the procedure like? Are there, you know, I know parents worry. They got this new baby.
Absolutely. And that's the biggest thing, when you come in to a doc who deals with this all the time, we're really treating the whole family. And we're treating the moms and the dads who are extremely nervous. They're dealing with their baby. The things that we really stress is, we don't oversimplify things, but we do say, yes, it is a very simple procedure with minimal risk. The
Yeah,
reason many of us who do large volumes of babies at this point choose laser versus scissors is, I think, when we deal with modern technology, you want to have what we consider the most advanced tools at our hands.
right,
For me, it's a laser. For me, it's a CO2 laser, which is very delicate on the tissues. Now, the nice thing about it is it cauterizes as it basically is cutting in simple terms, so you don't really get the bleeding, but you can
right,
actually see exactly what you're cutting. You can get to an endpoint, so you're not cutting too little, you're not cutting too much, you're cutting just the right amount to give you the best result, with minimal complications. When you actually talk about how the procedure works itself, for the most part, it's like a 30, 45-second procedure to do a lip and a tongue together. And
right.
in most cases, we don't give any shots for it. I do put a little numbing cream on the areas. Some people don't. I like to have some sort of, little anesthetic.
Hmm.
But the parents are always amazed at how fast it is. And, the feedback is always like, I got so nervous for this,
Right. That's
much.
good.
So those are the things that we kind of try to really kind of get in a nutshell. If you're going to somebody who does a large volume of these preferred providers, quote unquote, you should have a fairly positive, pleasant experience that way.
Right, right.
So
No,
I
that's
think it's
great.
important to get feedback from other people in your community. Social media is great for that. I think to get the feedback from in some of these tongue tie forums, you can go to get actual parents' testimonials and feedback, and they
Yeah.
can really the best people who can guide you through the process.
Yeah. Especially some of the forums where you have not just other parents on there, but practitioners that
Right.
are, IBCLCs, people like yourself, on there providing good information, sound information. And because the internet can be kind of the Wild West where everybody's got an opinion. And I know for parents, I mean, I'm dealing with it every day through my Facebook and social media, which is the majority of the work that I do, is that they're getting so much conflicting information, which is why a lot of people come to my page to have a trusted advisor online giving them advice and being sort of
Absolutely.
their teacher. And so if you're seeking that out, please just be careful of who you're taking advice from and not make yourself too crazy or confused, but try to find some good educated people that really have, not to say that parents don't have good information. Sometimes the best information can come from an experienced mom, but you can kind of get confused listening to too many
Absolutely.
different conflicting opinions. Um, what should a mom like expect as far as recovery? So is there like a big recovery time? When can she breastfeed? After the procedure?
So yeah, the average newborn, or say infant, so we're dealing with infants here. The average infant, I'll say, we try to get them latching immediately on the breast. So we do the procedure. The mom will basically take the baby, we go into a breastfeeding room, and we try to get the baby latching immediately, at least some skin to skin going, and try to get them on the breast. And a large percentage, I don't say 100%, but there's a large percentage that will start latching. Now, whether or not you feel a difference is not always, I say this is not always a magic bullet right off the bat. So we do talk about the team approach for this. But the average experience, and we can talk a little bit about the team, but the average experience is that I'll find that the babies are maybe they'll be okay, when they leave the office, and then they'll go home, and then they're usually kind of fussy. They have periods of fussiness. I usually find the first 6 to 8 hours is when the babies are, they can be, sometimes they're sleeping a lot, sometimes they're crying a lot.
Right.
They really kind of prep the families. I always say the worst case scenario, and we hope that it's going to be easier. But we just really, emphasize the skin to skin, breastfeeding, warm bath, skin to skin. We try not to medicate. If we do anything, we're trying, more of the natural approach to medication with homeopathic pain medication relief. So, we have a more holistic approach that way.
Yeah.
And then the team approach. So, we talk about that, it's not just you cut these babies and run and everything's fine. These babies really require work, and they require the IBCLC is what we call the team leader for these families, the surgical provider, and then many of these babies need something called body work or some other form of therapy. And reason being is that a lot of times because they've been feeding so poorly, they're compensating and using so many other muscles to feed. They might be using jaw muscles, neck muscles, back muscles, and get extremely tight. Sometimes they can be pulling off to one side or have torticollis. And many of them will need the help of what we call a body work, or it could be a chiropractor, it could be, a craniosacral therapist, which could fall under chiropractic or physical therapy or occupational therapy. So I think that's an important thing to think about as well.
Yep. Absolutely. And not only the other type of body work, but the parents themselves need to do some follow-up care as well, as far as stretching and
Yes. So, getting back to the actual procedure, once the procedure is done, there's work that needs to be done by the parents at home. Usually at least for the first 2 weeks, sometimes longer, where we will have to stretch the wounds apart, and that's to prevent something called reattachment. And that's really kind of the biggest risk of the procedure itself. And that's when you have open wounds after a procedure. If the wounds are just resting on each other, they'll heal back together or fuse back together. So we want to kind of actively separate those wounds while they're healing to prevent that from happening. They're very easy exercises to do, and the provider that you're doing it with should show you it or have a video of it to show you. In my practice, we show you the families how to do it, and we have them videotape it specifically on their own baby, because it is a very important part of the procedure.
Yeah. And I've seen people commenting before here, even on my page, that they had to go back and have multiple revisions. Right. And sometimes I know that can be from the reattachment, but sometimes it could also be, correct me if I'm wrong, but it could be also from not releasing enough.
Yes. Yeah, it's, and we find that a lot, especially with what we call the scissor providers. We find a lot of incomplete releases because they just don't go far enough back. And it's really because of the fear of the bleeding that you get with scissors. So that's another reason we find lasers tend to be superior.
Eliminates that. Yeah, eliminates that problem. Yep. We had a, let's see. So another question came in from Chelsea. She said she was told by her LC at the hospital that the baby had a mild tongue tie, and then the plastic surgeon, I guess she went to a plastic surgeon, said he didn't. Then she saw another LC who said he needed it fixed. Called to have it done, and the plastic said there was nothing to fix. Who should she believe? Her supply is low to begin with, and she doesn't want to have to cut him if it won't make a difference. What do you do if you the pediatrician or the doctor just does not think it's an issue, and why are they discouraging against this? See, this is the part that always it's so frustrating because it's like, why are they?
I think it's just a matter of education and experience and the understanding of the different classifications or types of tongue ties. Many times you'll see or hear that, oh, there's nothing to cut, but it's because they don't know how to identify the actual tie.
Mhm.
So they're looking at a posterior, quote unquote, posterior tongue tie or one that's further back from the tip of the tongue. And they'll say there's nothing to cut there, but there actually is. They just don't know what they're looking at. So
Right.
they're essentially a plastic surgeon. It could be somebody who deals with tongue ties or could not, so there's all different specialists in different areas, that it really comes down to the questions you need to ask that doctor. It's like, all right, how many do you do? How many do you do a week? How many do you do a month? How many do you a year?
Yep.
What classification system do you use?
Yep.
And when you start asking probing questions like that, you usually will find out, well, they don't really deal with these things.
Right.
Um,
So in this particular case, her LC would be the one to listen to.
yeah, the LC would
and
be
then
the
the
one.
second LC and third that she went to.
You have two LCs that are, having a similar opinion.
Yep.
And it's time to find a different provider, surgical provider.
Yep. Let's talk for a moment because we're getting to the end, but I want to talk about what are some of the long-term health effects? And we did have some questions that came in regarding older children. Like, is it too late? I think this one said her son is 4 years old, and let me just find this this question because this was a good question. Okay, would it be recommended to have an upper lip tie revised for a 4-year-old if there are no issues other than the extra skin causing a tooth gap and between the two front teeth? My 10-and-a-half-month-old was seen by our local children's hospital for his upper lip tie. We're told to revisit it at 1 year of age. Is there any advantage to waiting? And it was not pointed out by the physicians at birth, but sometime noticed myself. So, what would you say to someone with an older child now that's starting to recognize it? Is it too late or is it better to wait?
Yeah, so we find, a couple of things. In a child that you're starting to see maybe a dental issue develop or what we term an orthodontic issue where there's spacing in between the front teeth or maybe an excessive space. The indications for treatment, basically from the American Academy of Pediatric Dentistry, changed a couple years ago, saying if we're picking these things up earlier, we are recommending treatment earlier. And, excuse me, for a few reasons. One of them is the spacing between the teeth. Another issue, excuse me, you'll sometimes see that they have a difficult time keeping the teeth clean. So they'll go to brush the teeth, or their frenulum will actually collect food and debris, and it makes it very difficult for them to keep clean. There's studies looking at increased rates of decay with those lip ties. There's also speech issues that we're starting to really see. We're getting a lot of speech language pathologists paying attention to lip function with these things. So we are saying that it's never too late to take care of these things. We do find the earlier the better, but it's never too late. So we do it in all ages.
Right. So this can be, so you're talking about speech issues, you're talking about feeding issues, which may also be not just breastfeeding and bottle feeding, but we're talking about when you start to introduce them to solid foods and they're not opening their mouths, they're not, responding the same ways you would expect them to respond. They can have.
Yeah, many times, when we counsel families on this, we talk about, from infancy up through adulthood. So the infant, you may see issues with breastfeeding, maybe some gas, reflux. As they start to transition onto solid foods, many of these children, because they really can't raise their tongue up to the roof of the mouth or the throat, they'll have struggle with swallowing solid foods. And many of them will start to get labeled as picky eaters. And they go on and on. They'll see a feeding therapist and they'll say, oh, the baby's got a tongue tie, or child's got a tongue tie, needs to be addressed.
Right.
The next thing after that is usually a speech issue. And that, maybe 2-3 years old, you'll start to see issues with articulation. Sometimes you'll see a speech delay, or these kids that get labeled with quote unquote apraxias and they just are not speaking. But many of them actually have tongue ties, and you see that, they'll struggle with certain letters like maybe R's, S's, L's, and T's, and sometimes the H's, or we call the blends for the tongue. Sometimes the lips, they'll struggle with M's and B's or P's where they need lip, movement. And, the next big thing we'll see after that, besides dental issues, is, with breathing. And we find that a lot of these kids, when a tongue is restricted and it's not resting on the palate or the roof of the mouth, it's not helping the palate to spread out, especially if they're not breastfeeding at the same time. And the palate will start to actually get narrowed, and it starts to arch up higher. What that does, it actually starts to close off the ability to breathe through the nose. It actually closes off the sinuses a little bit. And many of these kids will start to become mouth breathers. And then that starts to lead to a whole host of things like potential snoring, sleep apnea, the open mouth posture, sometimes drooling. Many a times you'll see these kids have, more inflammation, more adenoid issues, tonsil issues. There are people looking at links to tongue ties and ear infections. Maybe they're not opening their eustachian tubes as much to help drain out the ear fluid. So those are things that we're looking at. And then there's things that start to affect, breathing, TMJ problems, head posture. There's a lot of things that we're looking at throughout growth and development. So.
Right. And even very long-term issues with heart disease and other things that we know apnea is linked to. So we're not just talking about a problem of infancy or childhood. We're talking about long-term, lifelong health issues, and that become much more difficult to fix and correct once the face is completely formed. We're talking about palates that are not formed properly, or orthodontia that's, so it's a whole host of things that it leads to for something that you described as such a simple procedure that carries so little risk, and you're already identifying small issues that are kind of foreshadowing what may be down the road. It may not be, right? But by the time you get to that point of knowing whether it is, it's a little bit too late.
Right. And that's exactly it. And that's when we talk about the risk, benefit ratio of doing something or not. And, when we counsel families on the risk of the procedure to do it, and you look at that balance, and when the risk is so down here and the potential benefit is way up there, it usually makes more medical sense to make that recommendation.
Yeah. Do you treat adults too? Because that was a question that someone had, is, that they've been able to find practitioners who are treating babies, but not treating adults.
Yeah, I do. I actually had a 74-year-old in today, which I work in conjunction with sleep apnea specialists. And one of the things we deal with, with adults, we see adults that, some are so severely tied they were never able to stick their tongues out of their mouths. It was a social issue. They were, unable to kiss. They were unable to eat ice cream or ice cream cones, had speech issues. And then also many of them who had, even the difficulty, moving their tongue to keep their teeth clean. There's a lot of issues. So we see it in all ages. And, I think a lot of people who treat infants, they're just more, they're focusing on that at this point. But there's a lot more that are starting to treat adults as well.
Right. Wow. Someone's asking in the chat room, what about pacifier use with a lip tie?
Mm-hmm. Pacifier use, many of us do not like long-term pacifier use because it can affect, jaw growth and development. As, sometimes I'll use it for exercises, with talk training and whatnot, but we really try to stay away from them as much as possible.
Right. We did a show with Anna Patras a couple weeks ago. She's an orthodontist here in my town, and my children actually go to her, and she came over to do an amazing show with us and the effects of breastfeeding on palate development and tooth development, and talked about, artificial nipples and including pacifiers and the effect on the development of the palate, and what you exactly were talking about, that arched palate. So there's just, nothing is an all or nothing. We don't say never to any of this, but we do want to keep in mind, and the more knowledge we have about how can it impact when that palate is so soft and moldable, the breast happens to fill out the palate. So it's the perfect spot for it and perfect thing to fill it out. And to just have that idea in mind of how that can impact their long-term development. It's important.
Yep.
Yeah, yeah. Can you believe the entire hour went by already?
Felt like 5 minutes.
It always does. It always goes really fast.
Days.
Oh my goodness, but we went over so much. Did you guys enjoy this? Did you get a lot out of it? Did you all learn something? I'd love to hear if you want to go ahead and just give me a little post there and tell me what you learned, something new that you didn't know before. Maybe it was everything, maybe it was one thing. And a big thank you to our special guest, Dr. Scott, because this was amazing. Thank you for being on with us. We've been waiting to have you on, and I knew this was going to be such a great show for everyone. And I learn a lot every time I listen to you, so this is great for me as well. But I know for the audience, it's been invaluable. They don't have this access to everybody to be able to do this. So to be with you is very, very special. Thank you for joining us.
Thank you. My pleasure. Maybe we'll have a part 2.
Yeah, we will definitely have a part 2. So, you guys go ahead and post questions. If there's things you didn't know or you didn't hear about or we didn't cover tonight, there's so much to talk about. And I'm sure Dr. Scott could go on for many more hours discussing this. Maybe we'll do an open Q&A the next time where people can just post their questions and we'll answer questions. But leave the questions for us because we'll definitely, I enjoyed being with you and I'd love to have you back again.
Oh, it was my pleasure. Thank you so much. I loved it.
Thank you. And if for everybody else, if we're going to have some really special live streams coming up, special events, great guests. I did put a link right here in the post so that when you get off of this, you can go to the link in the post that will, you could sign up for special notifications so you don't miss anything. I'll send you an email on anything new that's coming up, any special events, and you will be the first to know about them. Some of them will be private, some of them will be public, so I'm not saying much more about that, but go ahead and sign up and we'll be having some great stuff, especially coming up throughout the summer. All right, so time for me to go to bed. We're here on the East Coast and it's getting late, and I know Dr. Scott needs to get some rest because I'm sure he has an office filled with patients tomorrow. But thanks again for being here, and we'll see you soon. And good night, everybody. Thanks for joining us. Really appreciate it. Have a good night. Mwah. Bye, everyone.